The first topic we're going to talk about with the immune disorders is HIV or AIDS. You know what HIV and AIDS stands for, but the etiology and patho shouldn't be new information, so it'll be a quick review. It is a slow replicating retrovirus that has two divisions, HIV-1 and HIV-2. The virus acts by attacking the lymphoreticulator system, and particularly the CD4, for your blank, the CD4 bearing helper T lymphocytes. Right? So we use the CD4 as a way to also kind of judge or use that as a marker for where they are at. If that CD4 count falls below the 500 cells or the viral load rises above 5,000 copies, it's difficult for that infected individual to resist those opportunistic infections, meaning they're more prone, especially to fungal infections. So again, we use that as kind of the CD4 as a way to kind of mark how immunocompromised they are. There is no effective way to destroy the virus, so it remains in the body for life, and it can activate if the immune system becomes depressed. The antibody formation is decreased due to the B lymphocyte immune function. It's decreased. The antibody formation is decreased. We're going to talk about transmission. There's lots of ways that HIV can be transmitted. The typical things that we think about through sexual contact with blood and body secretions, sharing contaminated needles, transfusion of contaminated blood or blood products. But one that maybe you don't typically think about is, and how most children get it, is through prenatally, from the mother to the fetus or the newborn. So placental spread is still the most common reason for childhood HIV infection in the U.S. So in order to reduce that risk, affected women are offered the option of a C-section. There is the possibility that HIV can be spread through breastfeeding, because breast milk is considered a body fluid. So that is certainly a possibility. Probably a low risk, but it's still a possibility. You also have to think about children who've been sexually maltreated as a way that they could have acquired the HIV infection. So really important to think about those things. But prenatally and through placental spread is the most common reason for childhood HIV. Not transmitted through animal or usual contact. I've done a pretty good job in educating, but there are still people who think casual contact can certainly spread it, but that is not true. Let's talk about the assessment of HIV and AIDS. It has a long incubation period of about 10 years in adults, but in children, and especially children and infants, it tends to progress a little bit more rapidly. So those who receive that virus through the placental transmission, especially if the mother does not receive any treatment, are usually positive by 6 months of age, and they will develop clinical signs by 1 to 3 years of age. Children who receive the virus from another source usually convert to HIV positivity in 2 to 6 weeks, or at least by 6 months after exposure. During that pre-conversion time, the child may display preliminary symptoms like poor resistance to infection, fever, swollen lymph nodes, respiratory tract infections, oral candidus as well. When we talk about diagnostics, all infants who are born to an infected mother will test positive for the antibodies to the virus, because at birth you have the passive antibody transmission, and that will persist for about 18 months. So you cannot truly diagnose an infant as being positive for HIV until after they're 18 months of age, and that's because of that the passive antibody transmission. They're automatically going to test positive. So usually what we do is they're diagnosed by what's called recovery of the HIV antigen in children who are under 18 months, and we use the polymerase chain reaction. And if they're older than 18 months, then we use what we typically think of as the ELISA test, or the Western blot test, and that's testing for those antibodies. And remember, I said earlier too that We use the CD4 count as a way to document the disease status and predict the disease progression. So again, normal healthy count for an individual with HIV is between 500 and 1500 mLs is your normal count. When you think about the classifications and all the signs and symptoms that you get with HIV, you have a chart on page 2 of your notes that says category A, B, and C, meaning mildly, moderate, or severe symptomatic. When you look at those, I don't expect you to have like all those memorized. What I want you to recognize is moving from category A to category B to category C, is that we see a progression of the symptoms that we see, the severity of those symptoms, and obviously the more symptomatic they become, you see more problems with lots of infections and the seriousness of those infections. I'm not going to get that particular and ask for that kind of specific signs and symptoms on the test. I just want you to understand that there is a disease progression, and really we want to prevent them for as long as possible getting to those severe types of symptoms. So I really want you to focus on what HIV what it is, like the patho, the etiology, how it is transferred, especially to a child, and thinking about diagnostics and then looking into management. And again, just kind of this slide, it gives you kind of an overview of acute HIV infection symptoms, where the next slide gives you clinical manifestations of AIDS. Now let's talk about the therapeutic management for HIV. When you think about the therapeutic management of HIV, what we want to do is slow the growth of that virus. One way that we do that is by using antiretroviral drugs. Those antiretroviral drugs, they work at various stages of the HIV life cycle to prevent the reproduction of functional new virus particles. So the book gives one example, and the book example that they give is the zidovudine. So look at box 42.2. But with that medication, they often do follow-up testing for newborns being treated with it for the first 6 weeks of life. And if the child has 2 negative tests by 4 months of age, then the HIV infection can be reasonably excluded. One of the other methods that one of the other drugs that we also put them on is a prophylactic therapy for PCP, or the pneumocystitis carinae pneumonia. And we'll put them on the Bactrim beginning at 6 months of age. Prior to that, their body just cannot handle the medication. They can't excrete the medication like they should. So usually by 6 months of age, we'll put them on the prophylactic medication, antibiotic, to prevent those infections. Children who are more susceptible to tuberculosis than other kids, if they can be put on a couple of different meds if needed if they would develop tuberculosis. One of the bigger things to be thinking about with an infant or child who has HIV, is they need to remain and receive routine immunizations according to their usual schedule. Some of the big ones being pneumococcal and HPV vaccines, as well as influenza. They should be getting those. The ones they should not be getting are live virus vaccines, because of the fact that it's a live infection, depending on where their CD4 count would be at, they could have a hard time fighting, well, not just the CD4 count, but with live viruses, they would have a hard time fighting that infection because it's a live virus. Now, if it's a live attenuated virus, we use those in caution. It depends on where their CD4 count's at. So if they are symptomatic or they have low CD4 counts, then we may need to hold off on giving them those vaccines at the particular time. And typically your live attenuated viruses are your chickenpox or the varicella virus, and your MMR, which is your measles, mumps, and rubella virus. For the most part, they should follow a routine immunization schedule just like any other child. If they're actively sick, then we may need to postpone it. But the big one being live viruses versus live attenuated viruses that we're giving them. If they are exposed to varicella, we can give them the IV varicella zoster immunoglobulin to prevent the disease itself. And when you think about therapeutic management, one of the other big and important things is children who have HIV infections and their families need to maintain strict personal hygiene. the frequent hand washing, avoiding close contact with someone who is ill, because what you're trying to do is prevent those opportunistic infections that could be very dangerous to the child with HIV. If they would have an infection occur, then the antiviral and antifungal treatments are usually prompt and aggressive. When you think about your nursing care, there's a lot of education that needs to happen for the family caring for the child with HIV, as well as the child ages up. We need to do a lot of education with them. And not just with them, but we need to do education to especially teenagers and pre-adolescents as they get older about the risk certainly associated with sexual activity, the use of drug needles, things like that. So when you think about nursing care, a lot of it is aimed at a lot of education and prevention management. But one of the other things is nutritional management for these kids. It is a challenge because they do have a lot of recurrent illness and diarrhea and other physical problems. So nutrition is huge. A lot of the drugs too, they have nasty side effects, appetite suppressant, that just can really affect, and if you're constantly sick with nausea or diarrhea, and you don't feel like eating, then it certainly affects the way that you grow, because if you're not taking in enough nutrition, ultimately it's going to affect their growth. So we might begin to see their growth slow, or the weight begins to decrease. Again, it would go back to being how important are those growth charts for a child with HIV. We need to do education and prevention about the best ways to manage AIDS. One of the big ones, you should already know this one, is safe sex practices. Ideally, we want teenagers and individuals in monogamous relationships, or, if they're not, then we need to make sure they're using safe sex practices. Avoidance of substances like alcohol, drugs, those can cloud their judgment and they're not thinking as clearly. Again, when it comes to getting into sexual practices or the use of sharing a needle. We also need to teach parents and legal guardians. It's their decision whether they choose to inform a daycare center or a child's school about the child's HIV and AIDS status. They do not have to disclose that to those facilities. That is up to them. Because really those places should be taking precautions anytime they would be dealing with the child's body fluids, minimizing those exposure risks to themselves. So as long as they're following standard precautions, just like you would with any other patient, they shouldn't be at any increased risk. Important also to provide support and family for the coping skills, because this is a long-term illness. They're going to need extensive support, education, and anticipatory guidance for their child. Things that we need to teach about: education concerning the transmission and control of infectious diseases. That is essential for children with HIV infection and anyone who's involved in their care. You got to think about safety issues, proper storage of medications, equipment. They need to learn all of those things as well. And making sure that school personnel or daycare personnel receiving current HIV information. That doesn't mean that they have to know that the child has HIV, but as long as they understand what current HIV practice is and maintaining standard precautions, then they should be reducing their risk for transmission anyway. Okay, let's talk about allergies. Allergies are certainly a result of abnormal antigen-antibody responses, and basically when you have an invading organism like an allergen that is an allergen rather than an immunogen, it leads to hypersensitivity response. Those symptoms can be chronic and minor, they could be acute and severe, so it just depends on the child and how they react. When you think about assessment of allergies, you want to take a history. We can do some lab testing, some skin testing as well. When it comes to therapeutic management, our whole goals for therapy: reduce the child's exposure to the actual allergen identified, modify the child's response to the allergen, usually with a pharmacologic management, and if the symptoms persist, then we can even look at doing immunotherapy, which leads to producing a state of increased clinical tolerance or sustained unresponsiveness it's one of the kind of the last resorts. If the environmental control and the pharmacologic control aren't working, and it's severe enough, then we can do immunotherapy or hypersensitization, which I'll talk about further in just a little bit. Environmental control. If we can get rid of the allergen, whatever that allergen is for that child, first we need to identify it. If we can eliminate it, eliminate it. Although sometimes it's not possible to eliminate some of those environmental allergens. So definitely look at that review table 42.3 for common measures for environmental control of allergens. Some pharmacologic management or therapy that we can do, it's usually aimed at reducing symptoms. There could be intranasal steroids that can be used. We can use antihistamines. We can use decongestants. They're all aimed at trying to prevent the inflammation and the histamine blockers to reduce that edema. And as kind of a last resort, the immunotherapy or the hypersensitization is usually done when the child's symptoms cannot be controlled by avoidance or by conventional drug therapy. That can be done using allergy shots. That's the most common. And if they get an allergy shot, they should be observed for 30 minutes following the injection, just to make sure they don't have any sort of severe reaction. And it's usually continued for 3 to 5 years. And treatment with this therapy is not considered a cure. It's just increasing basically their tolerance of whatever the allergen is. Anaphylactic shock. I think for the most part you all probably know what this is. I'm not going to go through everything because it would have been a self-study. But anaphylactic shock is an immediate life-threatening reaction that occurs after the exposure to an allergen in a previously sensitized child. It can be fatal. There's lots of causes. There's food allergies, stinging insects, there's drugs, latex, and then depending on what their reaction is, your different assessment of anaphylaxis, you would need to be looking at their breathing, their circulation, their skin, their stomach, and just some other general symptoms as well. You can review that on your own. The therapeutic management for anaphylaxis. It's all about preventing and recognizing it that is important as to knowing how to respond to an anaphylactic shock. Epinephrine is our standard treatment, so oftentimes we think of the EpiPens, and it's given IM, typically in the vastus lateralis or an unaffected arm. And any child who has a history of anaphylaxis needs to be carrying those EpiPens, the epinephrine auto-injectors. And what those will do is they'll vasoconstrict to prevent and relieve the airway edema, hypotension, and shock. They also have a beta agonist effect, which increases the effectiveness of the cardiac contractions and leads to bronchodilation. I recommend looking over box 42.6 for emergency measures on anaphylactic shock. All right, we're going to talk about atopic disorders. And I'm going to go through atopic dermatitis, which is infantile eczema. There's also atopic dermatitis in the older child. That one is going to be self-review, because if you understand the atopic dermatitis, the infantile eczema, then you're going to understand a lot of the management is the same. There's just a few differences that I will point out. So atopic dermatitis or infantile eczema, it is a highly pruritic or itchy chronic inflammatory skin disease. It usually manifests itself, one of the first manifestations is of allergic disease. So oftentimes they'll develop allergic rhinitis and asthma. And the major trigger in infants is often a food allergy, for your blank, a food allergy. It is primarily a disease of infants, which is hence its name, infantile eczema. It usually can begin as early as 2 months and lasting until 2 to 3 years of age. Sweating, heat, tight clothing, contact irritants like soap just increase that itchiness. Symptoms are typically worse in winter. Why would they be worse in winter? That's because it's more dry, and when things are dry, they tend to be more irritating. Assessment-wise for infantile eczema or atopic dermatitis, they develop a papular and vascular skin eruptions with surrounding erythema. The slide before had a really good example of that. those vesicles will rupture and they exude yellow sticky secretions that form a crust on the skin as they dry, like in the picture on this slide. Those lesions are extremely itchy. The child will usually scratch, which further irritates the lesion, which leads to linear excoriations. What we worry about most in the young age group is they don't understand. You can tell them to stop scratching all day long, but they don't understand why it's so important to stop scratching. They just know they itch and they are trying to relieve that itch, but the problem is the more they touch it and mess with it, and then we worry about secondary infections occurring. And usually with secondary infections occurring, you'll see low-grade fever, pus-filled lesions, and local lymph nodes may be enlarged. And if they don't have a secondary infection, as those vesicles rupture and then form that crust, as those lesions heal, the skin becomes depigmented, lichen field, which means it's just shiny, and they have dry, flaky scales that form. The common areas you're going to see it, especially in the infant, usually on the face, the necks, and exterior extensor surfaces. They'll often rub their face, arms, and legs to relieve that itching. And as they develop the dexterity, then you start to see the focus on the flexural folds of the extremities and the neck. They often are fussy and irritable just because they're kind of miserable how itchy they are, which for those kids, they tend to not eat well because of their generalized discomfort. They can have a combination of poor sleep patterns, poor intake, and increased need of energy to repair those damaged skin, which results in a decreased nutritional status. Compared to the older infant, they, again, thinking about the areas that it occurs in, where the older kid, they're still itchy too. They get the dry, scaly patches, where the infant is, they're more moist lesions. And again, the locations on an infant being the face and the neck, where the older child with atopic dermatitis, it tends to be more on like their flexural surfaces of their extremities and the dorsal surfaces of the wrist and ankles. To diagnose a infant or young child with atopic dermatitis, and the infant usually presents with the atopic dermatitis and you need to have a thorough assessment for food allergy. Because most oftentimes food allergy is that trigger in infants. We want to look at family history, and we want to look at the characteristic lesions and their patterns. We've talked about this before about PKU. We may need to repeat a PKU to rule out the phenylketonuria, because there is an association with PKU and atopic dermatitis. And with PKU, they're not breaking down the proteins, which oftentimes those kids will have with PKU will have atopic dermatitis. Let's talk about the therapeutic management. Therapeutic management for a child with atopic dermatitis is aimed at reducing the amount of the allergen exposure. Again, if it's food allergy, then we want to eliminate that food. So most likely food allergies are milk, eggs, and peanuts. There are others. So oftentimes, how do I identify it? We usually use the use of elimination diets to identify that food allergen. So trying to eliminate the allergen itself. And then next we want to hydrate the skin. Hydrate the skin, usually by bathing or applying wet dressings for 15 to 20 minutes, followed by a moisturizer. That moisturizer is basically going to lock in the moisture in the skin so they're not getting so dried out. So it's really important after they have their bath is making sure that we hydrate them really well with an emollient to prevent that drying. We want to avoid harsh soaps, because harsh soaps and overheating are just going to further dry out the skin, which can exacerbate the symptoms. We also want to relieve their itchiness, so antihistamines, antipyretic medications. We encourage them to wear soft cotton clothing, because soft cotton clothing breathes, doesn't dry them out as much. You don't want tight clothing. We want to reduce the inflammation that's occurring. So reduce inflammation, we usually use topical corticosteroids. If there is a secondary infection present, then we're going to give systemic antibiotics to prevent, or not to prevent, but to treat that infection. And then lastly, we want to prevent and control secondary infections. So covering those lesions to prevent the child or the infant from scratching to reduce the chance of infection. Other things that can be done, putting mittens on them if they'll keep them on, clipping their fingernails short because we know they're not good hand washers, they're touching everything. Clip those fingernails short, reduce the amount of dirt and germs that can get into these lesions when they are scratching. And again, using the use of antihistamines and things like that to reduce the amount of itching will help as well. Let's talk about food allergies. With food allergies, you have an abnormal immune response that's caused by exposure to a particular food protein. And usually what happens is the IgE-mediated reactions account for most food reactions. They can manifest themselves in only a few seconds after the food is eaten. Sometimes you'll have additional symptoms that can develop over a period of 2 hours, and symptoms can begin gradually and crescendo into full-blown anaphylactic event. And again, food is the #1 cause of anaphylaxis. We've already talked about that. Important that every child with a history of a significant symptom with a food trigger needs an epinephrine autoinjector or an EpiPen and an anaphylaxis action plan. Most common foods that cause immediate allergy symptoms include peanuts, egg whites, milk, wheat, soy, seafood, and tree nuts. If they're allergic to milk, caution that they are allergic to milk products like ice cream, yogurt, and cheese. And if they're allergic to eggs, often they cannot eat foods that contain eggs like egg noodles, mayonnaise, things like that. Children with milk and egg allergy may be able to tolerate baked goods because they contain milk and or eggs, and that allergen, because of the high heat, is the reason they are basically able to tolerate it. So with baked goods, they can sometimes are okay with the products that use milk or eggs. Assessment-wise, sensitization can occur as food protein rises from the placenta or via the breast milk. First known exposure to milk, egg, or peanut causes an immediate type 1 response, which can lead to anaphylaxis. So typically your hives, your swelling, your vomiting. Other reactions are a little less intense, which can be more like in your atopic dermatitis that we just talked about. Important for a child or family to keep a food diary and record everything the child eats each day, and then document if any symptoms occur. The best way to spot the offending food that don't present with immediate It's the best way to spot the offending foods that don't present with immediate reactions. We often use elimination diets. They're effective tools in detecting mild food allergies. And because most of the foods that are implicated in food allergies are major food proteins, such as milk and egg, eliminating those foods has significant implications to the child's nutrition. So it is something else you have to think about, is when you've got a milk and egg allergy, how else are they going to get those nutritional things that they need? So certainly some education would need to go into that as well. When you think about therapeutic management, easiest treatment is to eliminate the offending food from the child's diet. So really important that parents learn to read labels carefully. It's important to educate, especially school-age children, how to choose foods that they can safely eat in the school cafeteria or summer camp to avoid those reactions. Important to watch the child's nutritional status at those healthcare visits, and maintaining those health charts as well. And milk intolerance is a leading cause of the type 1 reactions to food. Most infants can tolerate breast milk even if their mother consumes milk in her diet. Oftentimes supplementing with a hydrolyzed protein-based formula usually will decrease symptoms dramatically. That kind of goes, the milk intolerance goes right along with your food allergies as well. Our last topic to talk about in immune disorders is contact dermatitis. And contact dermatitis is an example of a delayed or type 4 hypersensitivity response. And it's usually a reaction to skin contact with an allergen. The first reaction is generally erythema, followed by intensely pruritic papules, and then vesicles. So the allergen causing the irritation is often suggested by the body part that has been affected. So for dermatitis from like diaper washing compound, usually appears in diaper area. If it's on the face, it could be related to cosmetic. If it's oozing from the site of pierced ears, it could be a nickel allergy from the earring post. Poison ivy usually is on hands and arms, or maybe their legs if they were wearing shorts, or the child brushed up against the plant. Children who have repeated surgeries, like spina bifida, are at high risk of developing allergies to latex, so they often will have lesions where the latex touches them. Assessment-wise, for contact dermatitis, we can do patch testing used to identify the contact dermatitis allergen. The big thing, if we do patch testing, the child should not be taking a corticosteroid at the time of patch testing because it will reduce or delay the hypersensitivity reaction. They can continue to take an antihistamine that won't interfere with the testing. And usually after 48 hours, the patches used for testing are removed, and then the reactions are graded on a 1 to 4 scale, the same as a regular skin testing. Therapeutic management. If we're allergic to something in the environment, or just like the food allergies, we want to identify what that allergen is, and we want to remove it from their environment. So for your blank for therapeutic management, remove the identified allergen from the child's environment. We can do dressings that are moistened with water, saline, or Burrows solution to relieve their itching. We can also use calamine. Calagel lotion is as effective as well for their itching. Hydrocortisone lotions and creams reduce the itching and they promote healing. Can use oatmeal baths, baking soda baths, things that are going to reduce the itching that is happening. Some children might need even like a sedative to relieve their discomfort if they've got really intense itching as well. Important for the nurse to document contact allergies on health records so healthcare providers are aware of them and can guard against those reactions as well.